Every year, thousands of Kenyans develop a blood clot in their veins. But what is this clotting all about? What are the signs and symptoms that you need to know in order to identify somebody who is possibly developing a clot, or if you have developed a clot? And most importantly, where do you go? This is Health Digest. I'm Dr. Mercy Korir, and we shall be demystifying what blood clot is, or if you've had deep venous thrombosis or venous thromboembolism, these big words that you probably have heard, we shall be demystifying them with Dr. Charles Kariuki, who is an interventional cardiologist, who will tell us what this cause of sudden death is all about. And I'll start, Doctor, immediately asking, what is it all about? Blood clot, thrombus, embolism, these are big terms that people actually suffer from, but what are they?
Right. Thank you, Dr. Mercy, for asking me to answer a few questions. And you're quite right. I mean, the whole clotting issue is a big issue in our society, and demystifying, as you put it, might be useful. As you've asked. So clots are basically blood coming together, clumping together, blood cells to form a solid structure, which can be very useful if you cut yourself and you need to clot so that the blood stops flowing, and you can injure yourself, and if you don't stop bleeding, it can be very dangerous. So clotting is a good thing. And the clotting mechanism is designed to help us. However, there can be problems. And as way back as the 13th century, people began to realize that there could be problems with blood flow. And when the blood is not flowing well, and it's pooling in certain parts of the body, it forms clots. And other things came to light, that if you injure a blood vessel, you get hit, or you break a leg, it's easier to get a clot. So injury to the blood system, to the veins or the arteries, can promote a clot. And then they also realized over time that it ran in families. So it seems like there might be some predisposition genetically. Exactly. So those are some of the factors, and well described by a few people. One of them called the famous Varkov trial, as we call it, triad, where if you have any of those three things I've discussed coming together, then you're prone to clot formation. So a clot is just the usual blood that we have coming together in cells, a few cells, and what we call fibrin strands that form from chemicals in our system, and they form a clump that's supposed to go and stop you bleeding somewhere. But if it forms inappropriately, can travel in your bloodstream, in the veins, or even in the arteries, and go and block off a very important artery or vein leading to an important organ and cause a stroke, a heart attack, or you can even cause your leg to be amputated because there's no blood flow. So what I've described are just the major areas that we recognize clots, but they can form in any place in your body, but they're only dangerous really in certain parts.
Mm-hmm. Okay, all right. And is there a group of people or a certain people who are more predisposed to developing blood clots as opposed to others?
Right. What you're actually asking is the concept of risk factors. Who is at risk? Okay. Now we do know, just to put it in perspective, roughly about 1 in 1,000 people will get a clot per year in any country. But the risk is different. The risk increases as you get older. So if you're under the age of 15, you have a much lower risk of getting a clot compared to somebody who's 80 years old. And that risk climbs very quickly. Similarly, we find differences between races. The Caucasians and the Africans seem to have a high incidence than, say, the Hispanics or the Asians. And that's from studies across the world. Again, we do know that pregnancy predisposes you to clots at certain situations. We also know that if you travel, you're at high risk of a clot. If you have a family history, there may be a higher risk. If you use hormonal treatments like the oral contraceptive pill, you may be at higher risk. If you have certain conditions like heart disease, or you've just had surgery, you predispose you. So those are called risk factors. For our situation, perhaps the most relevant might be if you're in hospital admitted and you're lying in bed and you've just undergone surgery or cesarean sections, or you've had a broken leg Those are the common
situation where
situations.
somebody is immobilized for a long duration
Exactly,
of time.
exactly, and not just immobilized, but there's something done to you to increase the clotting mechanism activity, so that you're even more prone to clots. So those are just some of the risk factors. But again, for population, perhaps long travel without walking out of your car more than 4 hours typically begins to predispose you, whether it's a car, aeroplane, bus. Yeah.
Are there any medicines or treatment or any treatment regimen that can lead to a high risk of developing clots?
Well, it's not easy to ascribe a particular treatment, but yes, if you're getting, for example, drips that have drugs that are corrosive, and typically we'll select, but if that's put on a small vein at the periphery, you can predispose you to clots. If you put a drip in the leg, you're predisposing that into a clot because you're irritating the veins of the legs. But again, put in perspective, these are situations where you're immobilized, that you say, and clots will form in the legs and the calf muscles, typically because that's where the veins are largest and that's where the blood pools by pooling, collecting, so it's easier to form clots. So if you've got those factors put together, there's a drug running in you that's corrosive, you're also immobile, you may be predisposed to clots. But patients with cancer, we must say, seem to have a heightened risk of clot formation in that particular group.
Mm-hmm. Okay, so it seems like it's a combination of several factors that would lead to blood clotting. And I know you've mentioned, like, if it blocks a vein that goes to a major organ, then there's a problem. So which veins are these that are most affected by the clots?
I think we would call them lower extremity veins, okay? But these are the veins in the calf muscle. I don't want to go into the names and so on, but the doctors amongst the soleus plexus, that is where typically veins will form, but they will also form in the femoral vein, superficial femoral veins, and that's why,
at the thigh,
on the thigh, on the inner aspect of the thigh. And these are important to us doctors because there are patients who come saying, I'm hurting on the outside of my leg. Okay, that's not the typical position. And we immediately say, okay, that can't be it. But the patient will know, ouch, my leg is paining and it's swelling, it must be a clot. So we need to educate ourselves, as a medical fraternity, where to go, where the money is to go for in terms of where you get the best outcome with investigating for a clot. So typically the femoral veins, but also what we call the pelvic veins. These are the veins within the pelvis. And many times you will not find clots in the leg, but you will know there are clots in your system because they've jumped to your lungs. But you will also find clots within the, what we call the pulmonary arteries that feed the lungs. They are actually veins on the right side, but we call them arteries, but they go and plug off now parts of the lung, and you get pain in the chest. And typically if you get a pain on one side of your chest, and it's worse when you're taking a breath in, and that pain is sharp, and you're a little bit short of breath, ask for help.
Mm-hmm. Yeah. Okay. And are there any other veins, let's say, up at...
Yeah, there are veins. I mean, there are veins that drain the brain. We sometimes get clots there. And your question of whether there are drugs that cause clots, typically we use the jugular vein, for example. These are veins that come from the head down to the center of the chest. Some will clot off. It's not a typical location for clots, though, spontaneous clots. Often those will have been provoked by infusions running through those veins, needles that have been inserted in those veins. And also, we do go for veins in the arms. Sometimes you'll see patients under dialysis or patients with other lines put in for cancer treatments or for even drips. You can form clots there.
Okay. So sitting at home, and probably I've had this conversation about veins, but I don't quite understand. How do I suspect that I may be having a problem? A vein could be in my calf, it could be in my chest. How do I suspect and know this is an emergency?
Right. That's a very good question. It's not that difficult, but at the same time, it's not that easy. Even for doctors, we say we should have a high index of suspicion. The reason we say that is because it's not always obvious in your face. However, having said that, if you have pain and swelling in an extremity, and particularly the leg, and mostly the calf, start thinking about a clot. If it's on one side particularly. If both legs are swelling, it's not that likely. It's not impossible, but it's not that likely. But you have one leg that's paining and it's swollen, and you think back and say, I've just come back from a flight. I've just come back from a long bus ride from Kampala. I've just sat for a long time in the office the whole day at meetings for 3 days. Or I was in hospital and I've just been discharged and I was in hospital for 5 days, we know that the risk starts from the second, third day of hospitalization for conditions such as pneumonia or other illnesses. If you're lying there, then begin to think I may have a clot. If you've had surgery to your leg and suddenly it's paining at the calf or it's now increased in swelling, start thinking of a clot.
Okay. And now when somebody comes to hospital, what are you looking for to confirm or to confirm that it is a clot or it's not?
Again, that's a very good question, but I'll just twist it a little. Most patients will probably not get to a hospital. They'll go to a clinic because the hospitals are only so many and the queues are that long. So we'll just say if you come to a health worker. Okay. Now, what do you expect is to be asked, why did you come? And you will say, I've got pain and swelling in the leg. Now, we try and teach that pain and swelling in a leg with those factors I've talked about is a zebra crossing the road, black and white stripes. It's got to be a zebra. And so the one thing that we must always think about as doctors is that's a possible clot. So we will ask you whether you took a long trip somewhere, whether you've been immobile, whether you have a family history, whether you got injured. Those are some of the questions. Are you on the oral contraceptive pill or any other hormonal therapies? So we'll ask you those questions. We'll ask you perhaps, do you smoke? Okay. Now, once we've asked those questions, that's called a history. We'll then want to examine, and if you're tender in a localized area where the swelling is, we'll suspect the possibility of clot. So you will expect your doctor to then say, let's do some blood tests and let's scan the leg. The scan is typically called a Doppler scan. And the blood test that we do world over now is called a D-dimer test. Now, I must say the D-dimer test is a very good test. If it's negative, you're not likely to have a clot anywhere in your system that would involve a large vein. Okay? However, it can be positive in many other situations other than clot. So just being positive doesn't mean you have a clot, but it's a very important test to be done and should be available in all healthcare units that see such patients. The Doppler scan is a more specialized test. In the counties, it will be available at level 4, level 5 hospitals and many other private hospitals, but the skill with which it's done is also important. So you need to present yourself to a facility that has a certain level of skill and get checked. So again, your choice of facility is important. You will expect to go somewhere where either the clinician is trained well enough to say you need these two tests, we don't do them here, let's send you somewhere, or you end up a place where they will be done.
So the fear, I'm just thinking, is a Doppler scan is an ultrasound. Wouldn't that destabilize the clot and probably throw it and have it move elsewhere?
That raises another very important question. I'll tell you, most patients will start jogging or doing massage and so on. Please don't. Anyway, yes, there's that fear, okay? But it's done very gently. And in any case, it's actually very painful when you've got a clot in a vein. So most patients will be in pain. And actually, that's one of the ways we can tell when you're on top of the vein and you find that it's painful. So it's unlikely they'll be pressing hard enough to dislodge anything. I don't think I've ever seen one dislodge just because somebody did a Doppler. You're more likely to dislodge it because you're starting to walk around and you have a clot in your leg.
Okay. So once you confirm, what are you doing? Assume you have a clot in the leg, the calf. What do you do?
Okay, number one, don't just go home. Get treated. Because again, there will be times when patients will not want to be treated for whatever reason. Get treated. And the treatment is fairly straightforward. We give blood thinners. And chances are you'll be given an injectable blood thinner to begin with. And you may well be admitted to hospital, but you don't necessarily need to be admitted, but each circumstance is different. So the assessment is very important. Has this clot jumped to the lungs or not? Is it a large leg that's likely to cause problems for you later? So the injectable treatments that we give are fairly standard world over. Often injection twice a day. It's calculated according to your weight, and very quickly, within 3, 5, 6, 7 days or 10 days, depending on where the clot is, you'll be transitioned onto tablets. Yeah. Okay.
So assume one has the clot is at the chest, at the pulmonary, they have a pulmonary thromboartery. The diagnostic modalities will obviously be different. Yeah. So which ones are they, and what do you do once you confirm? Because now this is one of the most life-threatening cases that any doctor would meet.
Okay, we'll go into doctor mode for a few minutes. Now, if your clot does jump, and it will jump in about a third of the cases that have DVT, that's important to know. And many times you won't even have symptoms. We just sometimes check and just and find the clots are gone, but the patient is actually not complaining. But once you suspect that the clot may have jumped up, it is very important to establish that. So the test that's done again typically is called a CT scan of the pulmonary arteries, or a CT pulmonary angiogram. However, we do have pathways, what we call critical care pathways. So if, for example, you come really sick and there's no time to take you for a CT scan, we can do a bedside heart scan. We call that an echocardiogram, and it will show us features suggesting to us that you could have a large clot in place, and that's standard across the world in many units that have such facilities. So we do an immediate echo and we start treatment. The CT scan should also be available, but not just any CT scan. You have to have a certain level of quality of CT scan, which were not widely available a while back, but now they're available in most units, and that's a CT pulmonary angiogram. That's fairly standard. There are other modalities. If you, for example, have kidney failure and you cannot have a CT angiogram, we'll do a radionuclide or radioactive study that will tell us. And sometimes we just have to treat without any of this, because the clinical examination will tell you. And we actually teach that about 2/3 of the time you can pick it just on clinical exam. Doing an ECG, you'll pick it. So again, we put all this together, come up with a diagnosis of clot in your lungs, and start treatment. And treatment is immediate. We don't waste. Once you suspect it, don't just send somebody off to go and do tests in the next town or next building. Start the treatment. Then they can do their tests.
And what is the treatment?
The blood thinners that we give them under the skin. Sometimes we'll start them intravenously. It's basically heparin. Heparin was discovered a while back, I think early in the last century, and it's been the standard of treatment across the world. Actually, for almost about 80, 90 years, we had nothing else really. But now we have other blood thinners derived from that same heparin, which are safer to use, more predictable, and that's what we use.
Okay. So do patients recover from these clots?
Yes. If you are to define recover, it would be a bit tricky. But yes, they do recover. But just to put you in perspective, about maybe 10-15% will not survive this. Okay? The clot in the leg or the lungs. And that's across many parts of the world. And so who recovers? The person who recovers, so to speak, is the person who has a clot maybe below the knee only, or sometimes just in the leg, that breaks down over time, because it takes a few weeks to break down. You can call that person as having recovered completely because it broke up. It can even be in the lungs, and you will check again in a year's time and you'll find all traces of the clot have disappeared. But that happens in only about 20-30% of people in terms of disappearing of the clot. About half will have a remnant clot in their system somewhere, which will be partially dissolved. Okay, that's fine. You'll survive, no problem. You may have leg swelling later on that needs to be addressed with stockings, and nowadays we do consider that we will continue long-term treatments to prevent you from getting another clot. So I think the word recover, if we say that survive, meaning you don't die, 90% of you likely will not die immediately anyway. But I must add that you have had these dramatic cases of, and I think you've seen that in the media recently, somebody collapses and dies, and they don't know what it is. A quarter of the clots in the leg, lungs, a quarter of those patients will not present to hospital alive, they'll be dead. Okay, so it is a fatal disease, let's not belittle it, and about a quarter will not make it to hospital to begin with. So those who make it to hospital, now we are talking about the survival of that. Yeah.
Okay. And so is this 90% survival rate here in Kenya, or is it global? Because looking at the health infrastructure and the health system in Kenya, then some of these things may not really be readily available to people all over the country. So is this 90% to everyone?
That's a very good question. We don't have clear, firm statistics. As you know, to get the data from all our health units is not easy. Okay, we might need the IBC to help us, I don't know. But we need to get that data to be able to answer such a question. So we have to borrow from other parts of the world what we know. However, we do know that diagnosing a clot with a Doppler scan, I mean, how many units can do that? Quite a number, but still we have a larger number that don't even have the equipment. And some even have the equipment, but they don't have the necessary software or the skill. So we miss quite a bit, that's for sure. The survival, however, once you make a diagnosis and you begin to get your heparin treatment, it does very, very well. A number will go on to not survive within a month or two, but those are people who have complex other diseases usually. They have heart failure, they may have cancer, or they may have other abdominal infections, etc. Such people, yes, but a clean clot that's been discovered on treatment, relax, you're going to be fine, usually.
Yeah. All right. Then last, so because it's a fatal disease, can it be prevented?
It can. I mean, in the typical situations, and that's again a very good question, we do have a pharma industry for various reasons, you can imagine, who have helped us to develop tools to predict. So every patient coming, for example, in my hospital where I practice, the Nairobi Hospital, you will get a score in your file that's trying to assess your risk. It's called the VTE, the venous thromboembolism score. That score is meant to guide us. If you score over a certain number, we then know you should be on these injectables we're talking about to protect you. So in the hospital setting, we have a well-organized system that needs to be actually spread out across most, all health centers, how to assess stroke, or should I say clot risk. Okay, but out there, if you are traveling or you are sitting for long periods, or you're beginning the hormonal treatments for whatever reason, or you're on cancer treatments, or you have a family history, a strong one, because you will find some families, 3 people have died of clots going to the lungs, then you need to go and see a doctor who will guide you with what to do. But usually, typically, for example, if you're traveling a long distance, you may take a pill that's going to prevent a clot, or an injection that will allow you to travel to the United States, which is X number of hours, or if you're going to the border by bus, you need to remember that, or just get out and walk every 2 hours. If you're on the plane, we teach you to move your feet so that you activate what we call the muscle pump that moves blood up. Yeah.
And what about compression stockings?
They do help to some extent. Yeah, they're not fantastic, but they do help.
They do help.
Yes.
Okay, all right. Anything else you may want to add?
Well, I don't know. Maybe just creating awareness amongst the public, I think, is where a lot of the benefit is going to be in terms of dealing with this condition. Where if you get pain and swelling in a leg, don't start going to the gym or go to the massage places to go and ask for help. And you'll get helped if you go to the right place. Okay? Now, once you get that kind of diagnosis, you have to have an idea of what needs to be done so you comply with it, or even sometimes prompt. I've had patients who've told us, look, I think I have a clot, when we were not thinking about it. So again, the public needs to know. And of course, now the burden is on us as health workers to make sure our systems are correct so that we risk assess, make correct diagnosis, correct treatments.
Okay. Thank you very much, Dr.
My pleasure.
Thank you very much. I think prevention here is definitely better than cure, and it's always better to be safe than sorry, because this clotting issue is a killer. It's a killer disease. So you need to know these risk factors, what you need to prevent developing a clot, and when you develop a clot, seek the right kind of medical treatment.